In a short axis, you can appreciate that there is dilatation of the right ventricle here. So this is the right ventricle, tricuspid valve, right atrium, and this is the aorta. Sometimes you'll have also pulmonary regurgitation, pulmonary valve regurgitation. If we are lucky, we can also find a dilatation of the pulmonary artery. We will show you some images now. This is the pulmonary valve. There is some regurgitation, pulmonary artery, and this is the branches. This is the right main pulmonary branch, and this is the left.
Can we find the thrombus and?
Sometimes we can thrombus. In this case, we don't have thrombus because this patient was already thrombolized a few hours ago. Anyway, we can find thrombus. Okay, if you have a better image quality, this patient has pulmonary regurgitation. If you find a dilatation of pulmonary artery, this is very suggestive of pulmonary hypertension, either pulmonary embolism or other causes. And there is some tricuspid regurgitation in this case. And when we estimate the pulmonary pressure, we don't have adequate jet here. This is a very important view or image. And this is called short axis through the left ventricle and right ventricle. Left ventricle is normal in size, even is small. Right ventricle is large, is almost double to triple size than LV. And this suggests that we have a severe overload. Why the septum here is not a circular? I mean, LV, left ventricle, is not circular in shape. This is called D shape. And if we freeze this and move in the cardiac cycle, you will find in systole you have compressed septum toward the left ventricle, which indicate that this is a severe systolic pulmonary pressure or hypertension.
Excellent.
And in diastole, this is systole. In diastole, it will expand little, and this indicates both volume overload and pressure overload in the right ventricle, which is surrogate to the pulmonary pressure. Again, we are playing this image. This is very suggestive of severe pulmonary hypertension. How can we know this is acute or chronic? To be honest, if the patient has all the study echo and now there is a reduction in or there is increase in pulmonary pressure and side, this will indicate this is acute. If the patient doesn't have, so we have to correlate with the clinical findings. Again, the same, you have this D-shaped septum. The RV is pushing the LV, which is unusual. And this indicates in systole, the pulmonary pressure is more than the LV pressure. What's the LV pressure? Usually is the same of the systolic blood pressure of the patient.
Excellent.
And usually if you find this sign, at least the systolic pulmonary pressure is 60 or more, which indicates severe pulmonary hypertension. Now we'll go to one of the most important views, which is the apical fourth chamber. Unfortunately, again, the patient was obese, morbid obese, so we cannot get better images, but you can appreciate that the right ventricle size is larger than the left ventricle.
Normally, which one is bigger?
Sorry?
Normally, which one is bigger?
Normally, LV always is bigger than the RV.
Okay.
Because LV is the pump of the body, pump of the blood to the body. RV is just a reservoir for the blood. Normally, LV is double than RV. Here, if you concentrate, so this is the left ventricle, this is the septum, interventricular, and this is the right ventricle wall, lateral wall. If you see here, the right ventricle in size is larger than the left ventricle. We have to do color. Again, this is very good image. You see that the right side is larger than the LV, the right atrium is larger than the left atrium, which indicate also there is a high blood volume inside the right side or the right side RV and RA. And the septum motion is pushed toward the left side, which indicate a high pressure inside the right ventricle. As we see also, the systolic function of the right ventricle is impaired. So this is not a normal right ventricle. Normally, it should contract. That means two walls, septal wall and lateral wall, should contract and should become very adjacent to other. Here, no. This is hypokinesia, low ejection fraction of the right ventricle. On the same side, same time, we can appreciate that the right apex is hypercontractile. I mean, there is a strong beating of the right apex. And this is what we call a typical McCone sign, which is highly suggestive of massive pulmonary embolism. It is
But
not,
this is
not
indirect.
sensitive, indirect.
Indirect evidence.
By the way, all of echo signs are indirect for massive pulmonary embolism. We can find most of these signs in any case of acute pulmonary hypertension or chronic. By the way, McCone is more suggestive and indirect for pulmonary embolism, not any other type of pulmonary hypertension.
Excellent.
Again, it is not sensitive but specific. That means if you find this sign, more than 90% you are dealing with massive pulmonary embolism, usually acute. If you don't find it, you cannot rule out pulmonary embolism. By the way, even normal echo doesn't rule out pulmonary embolism. We are talking about mild to moderate or something like this. There is some TR. Anyway, the most important, which I show now finally, that we have always to take the gradient of the pulmonary.
What's the
Here we
normal
can get
gradient?
the normal gradient in the RV, I mean, this is the RV pressure, which is the same of pulmonary artery pressure, except in one case if you have a severe pulmonary stenosis. The normal gradient up to the systolic up to 30, and finally they say up to 35. This is the systolic. And the mean usually is about 15. So if you have the systolic, which is measuring by echo, up to 30 to 35, this is a normal. From 35 to 45 is a mild. 45 to 60, and the last guidelines, they said even 70, this is moderate. More than 60 or 70, this is severe. So this patient, to know what's the pressure, this is at least 45, and this is the tricuspid velocity. So we have to add usually 5 in normal patient. So if the patient is normal, this is 60. But if the patient has dilated right ventricle or right atrium, we add usually 5 to 10. Dilated IVC and non-collapsing 20. So this patient roughly have pulmonary pressure about maybe 70 to 75. To be honest.
75.
Yeah.
Okay.
The last image, which is important, but we couldn't take in this patient because of heart condition and obesity, the IVC is very important. If you have dilated IVC, that means you are dealing with severely pulmonary hypertension, and especially dilated more than 2 centimeters in diameter, and not collapsing. Collapsing, that means on inspiration it is collapsing more than 50%. This indicates you have a very high right arterial pressure and surrogate to severe pulmonary hypertension. And it's very important for follow-up. The role of echo also very important, adjacent to diagnosis, number 1. Number 2, you can follow the patient after successful thrombolytics to know there is improvement, and even in the follow-up as outpatient later. Because as we know that some patients, they will develop chronic thromboembolism.
So the take-home message from you, Dr. Baraa, about the role of echo.
Role of echo, don't depend on echo for ruling out or ruling in pulmonary embolism. It's very important and helpful to support our diagnosis, especially if we have a clear sign. Negative finding echo doesn't rule out pulmonary embolism. We have to depend on clinical finding, as we know, other parameters, especially CT, pulmonary angiography, if we have a high suspicion. But sometimes we cannot depend on CT, or we cannot do if the patient has renal failure, patient in critical care situation, in ER, the patient already intubated now, or in CCU or ICU. So echo is very helpful, and sometimes we can depend on decision of thrombolytics.
Thank you, Dr. Baraa, for informative and enlightening explanation of the role of echocardiography in diagnosed pulmonary embolism.
Okay, thank you very much.